right, welcome back. I'm Michael Stamatinos, your host with the Advancing Healthcare Innovation Show. And if you're new to us, we are super excited to have you here. We also happen to be extremely passionate about healthcare innovation and adoption, as well as access and leadership. And if this is your first time tuning in, let me tell you a little bit about what we do here. So we're a healthcare innovation focused company, and we're bringing real people that have real stories of innovation within healthcare to life. And our aim is highlighting real people that are actually truly innovating within our space. Now, for those, if you haven't checked out any of our previous interviews, we've had an incredibly action-packed year. We're going to have an even better 2023. Super excited about that. So without further ado, I'm delighted to have our next guest, Dr. Aiesha Ahmed, who is the Vice President of Population Health, as well as the Chief of Neuroscience at Corewell Health West. Dr. Ahmed, welcome to the show.
Thank you very much, Michael. Excited to be here.
Yeah, super pumped to have you. So if you wouldn't mind, I think maybe just to kind of do a little bit of a preamble of your background, your history. I know that, as a clinician, you're very much tied into day-to-day, but maybe kind of give the viewers a little bit of your core story, and then we'll kind of dig into some of the fundamental things that you're doing now.
Sure. So I'm a neurologist by training, in fact, a neuromuscular neurologist. I started, as most of us do, started specializing and then subspecializing. And then in that process, realized that I was making a great impact for patients with that subpopulation that I saw. But I was so used to converging, that I didn't really understand the macroeconomical landscape of healthcare. So I felt like I had blinders, and I wanted to change that. And I wanted to really think of a way to make my way of looking at the world a little wider. And I decided to get an MBA, and I was at Penn State at that time. So the MBA was very, very helpful. It gave me a chance to understand really the team dynamics, working with others who are from different backgrounds, to really truly understand what stakeholders mean. And through that process, continued my leadership journey within healthcare, and ended up at Corewell, previously known as Spectrum Health. So I may make the mistake of calling it Spectrum from time to time. I've gotten better. And I've been a Chief of Neuroscience for about almost 3 years now, and the VP Population Health role has been a little newer, almost a year. And the reason for this role was an interest in understanding value, really understanding the quadruple aim, and focusing on moving us away from sick care to keeping people healthy, moving us away from inpatient to more ambulatory care. And has been a really exciting journey. I'm learning a ton, and have more questions than answers as time goes by.
Don't we all?
So true.
Wonderful. Keep going. Sorry, I didn't mean to interrupt.
No, I think that's what has so within my role within neuroscience, I oversee neurology, neurosurgery, PM&R, which is physical medicine and rehab, interventional pain, and neuropsychology. And Corewell has a very interesting model that we are not very siloed within service line, within departments. So we are service line model, which is more patient facing, and I think it's easier from a cross-functional standpoint. And then population health is a fairly newer endeavor for Corewell. And when I say newer, it's been about 2 years. And what's really exciting about population health is an opportunity as the largest healthcare system now. But previously we were a fairly large healthcare system for West Michigan, but now we're the largest healthcare system for the state of Michigan. An opportunity to really think about value for the patient, value for the communities, at the same time really understanding how the provider experience can improve, and how we can do things differently and be more innovative. So that's kind of where the next chapter will be for us, really trying to think of new ways of delivering care, and really thinking of ways where we're really focused more on keeping people healthy, thinking more about preventative care instead of just the usual siloed care, which is specialty focused sick care.
You mentioned earlier about having multiple stakeholders and kind of having some business training to understand that. How has the transition been from educating different stakeholders about going from fee for service to fee for value? What have some of those conversations look like internally?
That's a great question, and I think what is really interesting is that it needs to be different depending on who the audience is. So most physicians or providers, APPs included, are not really very focused on whether it's fee for service or value. They just want to provide the best care they can. They want to do the right thing for the patients, diagnose accurately, provide the best management based on standard of care, evidence-based. And most of us are not trained to really think about fee for service or value-based care. But what has happened over the years is that there are all these economics of healthcare, where how are we getting paid, how are we billing, all these administrative burdens have really weighed down providers. So from that standpoint, the idea that we need to really be thinking about the best way to provide care in a way which is not fragmented, where the right physician is providing the right care to the patient in a way where the access is really designed around the patient's need instead of waiting from one specialist to another specialist and being bounced in different directions. And to patients as well as to the providers, this is very appealing. Now, of course, there's the economics of it, that how do we design such care? And I think that's where the change management is pretty crucial. What is value-based care? How is that different from population health? What are value-based care payment models? This is a new vocabulary for most providers, and some people have to learn from the beginning. Some people are a little bit more advanced. So I think the message needs to be really designed based on who you're talking to. And then what's really another aspect of this is to understand the relationship between payers and providers, which is a term, payvider, that has been coined and is used
Yeah.
in different ways. And that's something people are just getting used to, or at least getting exposed to. I wouldn't even say most people are used to it. So really understanding that there are ways where we can all work together, and certainly integrated healthcare systems allow that. So I think this has been most interesting to me, that who your audience is and where they are. So really
Yeah.
meeting them where they are as you're sharing information with them, and also really explaining the big picture idea, right? I mean, not really just from a economical standpoint or how we are going to be paid differently. It's really maybe focusing more on things that we can do now, which we couldn't do before, that focus on that preventative care, keeping patients with their primary care physician for most of their care, and really not utilizing specialty care unless it's really needed. Does that
Yeah, no,
help?
absolutely. So a few things come to mind. So you've taken this leadership role in some very interesting times, and I can only imagine from when you've taken over to where you are now, there's been even more transition, things, a lot of moving parts. What have been maybe some examples, some stories that you're able to cite that kind of talk about how you guys have innovated as things are evolving mid-flight? Anything that you can kind of share that might make the concepts that you just explained a little bit more concrete from a use case standpoint of view?
Sure. So one example would be really primary care redesign. How can we focus on primary care in a way where there can be coordination of
Yeah,
care within that clinic model? So patients have biopsychosocial needs. So of course, primary care clinics have traditionally not been equipped to have a wellness coach or a behavior coach or therapist available in that setting. So even though we say biopsychosocial, we are really not taking care of the psychosocial aspect. Then
mm,
there is that social determinant piece, right? Where are these patients from? What are some challenges at home? What are some challenges in the community? And how can we really be thinking about that as patients transition from inpatient to outpatient, emergency room to inpatient, or emergency room to home? So there have been some great projects with good outcomes. Again, we are still early in our journey, but the primary care redesign has been very successful for elderly population, where the panel size for the physicians has been very appropriate so that they have more time for patients. The focus really is to provide them with that wraparound services that I mentioned that are not usually structured in primary care setting. And a more concrete example I can give you is e-consult. For those of you in your audience who are not familiar with e-consult, it's an asynchronous communication using a tele platform. It could be EMR, it could be any other way, but it's asynchronous. And it has been utilized in different settings. What we are doing is utilizing the e-consult between a primary care provider and a specialist to improve access. So when I say improve access, what I mean is that there are some billing and coding opportunities with e-consult, but we are not using that at all, actually. What our hope is that if we are able to utilize this asynchronous communication and ask the right question, the primary care physician may get the answers that will allow the primary care physician to take care of that patient instead of the patient waiting for like 2 to 4 weeks or longer to see the specialist. What we are also hoping is that it will allow us to, the term I use is like shape the demand for care, meaning that the specialists are really seeing the patients they need to see and are able to guide the primary care physicians for areas that can be managed by primary care with some guidance instead of the patient having to wait for a long period of time. So really you're shaping the demand for the right care for the right specialist. And at the same time, what we are hoping with this e-consult is that we are reducing fragmentation of care so that patients can stay with the provider they know. Primary care is the provider who they have known for a very long time. They have a relationship with this provider. Now they can really be depending on this provider for these specialist type of questions and management of disease such as diabetes or a neurological complaint. Of course, you know, at some point they may need to be referred out to a specialist, but the fragmentation of care as a physician, I feel is a pretty valuable thing for us to think about, because so many times you see patients who, when you ask them, who gave you this medication? And their answer is, oh, I don't know. I see like 5, 6 different doctors. I have no idea. Don't they talk to each other? So that's kind of what we're hoping, that that's where the value is for the patient with this e-consult, that the patient will not be getting care from different specialists, but will get their care even for their specialty or focused disease through their primary care. So that's one example. Another example.
Quick question about that. Does that, it sounds like what you're saying is that instead of just blindly sending a patient to a specialist, there is now a way that that intervention can happen at the PCP level. Are you finding, and this is just what struck me initially, are you seeing that maybe there's what kind of reaction does that provide, occurs to the specialist as well as to the PCP? Does the PCP feel having now more and more responsibility, more risk that they're taking on? I guess what have been some of the reactions on both sides, and how have you sort of mitigated both of those?
That's an excellent question, because you're absolutely right. It can be more work for the specialist and for the primary care physician. And it's very important to have the right infrastructure. So in order for us to do this, we cannot be expecting physicians on either side to just randomly take out 5 minutes, 10 minutes while they're seeing patients to do this. So that's where the infrastructure piece is really important, that where is some dedicated time assigned to answer these questions. How can we make sure that these questions are documented in a way where it's almost like a note that can be referenced later on? So for the e-consult, there is a template that we use EMR. It has very specific questions, almost like a checklist type of a function. So if the reason to do it this way is that certain rules need to be set up in order to make sure that this is not unnecessary extra work for either one.
Yeah.
The average time should not be more than 10 minutes. If it is more than 10 minutes, that means that this first patient requires more investigation, more evaluation, and then e-consult is perhaps not the right approach for this particular patient, and a more traditional referral would be indicated. Going back to the redesigning of primary care, so in order to do this, we absolutely have to have the right panel size for the primary care physicians. If they are seeing patients every 10 minutes,
Yeah.
they obviously do not have time for this. And I think that's why I think this is a very important question, that as we approach any new innovation, it's important to really understand, why are we doing this? What are our goals? What are goals for all stakeholders, right? We talked about patient, we talked about specialists, we talked about primary care. And then how can we design it in the right way, where we can make sure that it's standardized, so that the experience for all the stakeholders should not be different depending on who the individuals are who are performing that e-consult. So I think that infrastructure piece, making sure that we are leveraging the EMR, we are setting up templates, and we're trying to create things in a way which are automated, is very, very important as people experiment with this. But yeah, I have heard of places where it has not gone well because time and other factors, understandably, created challenges with making this a success.
Well, I can only imagine, Dr. Ahmed, that you talk to peers across the industry and you try to figure out, well, if things haven't gone well, what were those learnings? And then you're obviously trying to modify and make those approaches. It just sounds like at Corewell that your approach is highly collaborative, that there are multi-stakeholders from specialist groups as well as on the PCP group side of things. That are these specialists and PCPs, are they employees of Corewell or are they independents? What can you maybe talk a little bit about that makeup, and does that make a difference?
Sure. Yeah, I think it does make a difference, because it all starts with a why, and then once we have established the why, how. One of the advantages we have is that we were not thinking of e-consult as a billable activity, right? So we weren't thinking of e-consult as a revenue generating activity. Now it can be. There are billing codes for that, so it can be. So that's why I'm repeatedly saying the why is important, because when we thought of doing this, our thought was, how can we reduce fragmentation of care? How can we do demand shaping for our specialists? Because there is a national shortage of specialists. You just cannot find them. I mean, you could create positions, you can have a very good recruitment process, but there is a national shortage. So those were like the two big whys in our mind. And then the how was in some ways helpful for us, was the aspect of our own insurance arm. So we do have Priority Health as our insurance arm. So as a pilot for e-consult, we focused on patients that are our Priority Health patients in risk contract. And that allows us the flexibility of designing their care, so that we don't have to be thinking about setting aside time, which is not billable time, right? So I think that the ability to have that pay wider relationship and utilizing that in a way that is mutually beneficial for all stakeholders is critical, I think, for the success of this model. And when I say stakeholder this time, who I mean even including insurer. So the payer is a stakeholder. And from a payer standpoint, if e-consult allows this patient to get answers, so we'll just use an example. So let's say it's a patient with newly elevated hemoglobin A1C, and instead of waiting, and I'm simplifying this example, most of the time primary care will handle this, but just as an example, we are using it, that let's just say there's certain other risk factors that the primary care wanted endocrinologist to provide the input, and instead of waiting 6 to 8 weeks, a patient could be started on a medication, and now this patient was able to manage their disease earlier while they were waiting. They didn't go into any crisis, which would let them which will set them up to go to the emergency room or urgent care. So from a payer standpoint, we have managed the disease in the outpatient setting quite well. So that yes, there hasn't been any billable activity around e-consult, but we have prevented emergency room utilization. We have prevented hospitalization. And I think that's where the return of investment is for the payer.
Yes,
I think
absolutely.
payer relations is an important piece that we were able to leverage. And I think if one is not able to leverage that, then one has to think of a different model. And they are. When I was at Penn State, we were thinking of doing e-consult mostly from the demand shaping standpoint, and it was going to be a billable activity, and there was protected time for it. There was time designed for it. And again, there was some standardization of templates. So that was also a model that when I was leaving Penn State, we had started, and it was working. So I think one has to really understand not only just their why, but in order to address the how, who are the different stakeholders that you want to bring to the table as you design that process.
So moving into this new year, at the time of this conversation, curious, what are you most excited about? What do you find that there's the biggest opportunity that you can make an impact on in this new year?
Yeah, that's a great question. I think there's so many opportunities. So as you have been hearing and talking to different people who you bring for conversations, AI is a really big area. And what does that mean? We have a lot to figure out, but it's certainly very exciting. So AI-based preventative care models are very exciting to us. Specialty care redesign, where we have already started at Corewell West in orthopedics and neuroscience. And this redesign is really thinking about creating an integrated practice unit called IPU. And what does that IPU mean? For our patients, it's obviously once we pilot, we will know better, but our hope is that can we really be thinking about osteoporosis even, and healthy spine, healthy joint around the preventative piece that traditionally orthopedics or spine groups have not really thought of, because who owns that? How can we leverage AI for that? How can we really think about chronic disease differently so that we are preventing surgeries or delaying surgeries if we can? And how are we thinking about using unique services such as pain psychology and group appointments in order to help these patients, and again, addressing their biopsychosocial piece. So the IPU is the next big thing that we are working on, and we hope to go into other specialties. As I said, what does AI mean for us is I think it's all healthcare systems are thinking about it. And I think with that really comes those big questions about the governance structure, the framework that needs to be utilized. And I think that's really exciting. Remote patient monitoring, what would that mean for not just primary care, but specialty care is very exciting. So I think I can list many different areas, but I think the way I want to approach this is the exciting piece about population health or value-based care in the future is really that focus on preventative care and where that preventative care will exist. Is this going to be highly technology focused at home through primary care, other stakeholders that we have not been thinking about, other collaborators that we will be partnering with? And then the other big area is the chronic disease management. And again, who are going to be our stakeholders for that? And how we will collaborate with them is going to be, I think, the focus of 2023, and certainly seems very exciting to
how do you prioritize? I think because you only have so much bandwidth, and if you think about the opportunities that you have in your mind, to the degree that you're able to share, is there sort of a stacking in which how you prioritize these initiatives?
Yeah, I think it's a great question, and different organizations will approach this based on their patient population that they are serving. One thing I can tell you is that the pandemic brought a few things too light for all of us. One was capacity issues, where
Yeah.
everybody has realized that we have just not been able to manage the demand for this inpatient care needs that due to the despite being a large system, capacity was, we were always at capacity or over capacity, and that led to a lot of deferral, and that led to people going further into their chronic disease, which was not the best managed. And these things have really highlighted the need to think about virtual health opportunities and how to use the teleplatform in different ways, and really focusing on that on the ambulatory side more so than just the inpatient side. So I would say that the recent 2 years experiences have created some prioritization for us. So I would say that ambulatory care with a big focus on virtual care is going to be certainly a high priority. Certainly, we are trying to think of ways or develop tactics that can keep patients out of emergency room, out of urgent care, and also think about ways to create models within EMR so that the new care models that we develop are easy to implement and easy to measure. And because there is that physician provider aspect that we have to be thinking about, that we don't want to make things more difficult for teams that are already very busy and are stretched very thin. So how can there be ways to leverage EMR in a way where these new care models are easier to implement? So I would say those are going to be the main focus area. But again, so many things are happening that we all have to be mentally prepared that we may need to pivot.
Yeah. Yeah. And you know what it sounds like, since you've been making so many brilliant comments throughout this conversation, is it sounds like your areas of focus are also kind of combining aligning things, whether it's aligning internal stakeholders as well as, I'll call them the external stakeholders, the payers, and getting all those things aligned. And then moreover, is viewing things from it's kind of like a human-centered design approach, looking at how are we doing things and how can we kind of improve them, get continuous improvement to the point where then we can kind of leverage the AI. So you're kind of going like a crawl, walk, run, sprint approach. You're not just going from we're crawling, now we're sprinting, but it's sort of a step function improvement to the point where you're getting to the point where you can do those really interesting, innovative things. And to that kind of point, that question is it sounds like a lot of the innovation that you're doing is, like as I mentioned, process improvement. And then to what point are you doing external innovations and then bringing them in? Like when do you find that that's an area of interest where you can, plug in an innovative and interesting digital health startup? What is that thought process like, for your organization?
Yeah, I think that probably does exist, not an area that I'm focused on, because we do have an innovation team that is always looking for different innovative ideas that they bring to the clinical teams or to population health to pilot. I would say that even those innovation opportunities are mostly focused on process improvement. If you really think about it, for example, remote patient monitoring. If you even though yes, it's technology and it can do various things, but if it really truly is process improvement, right? So ideal state, and we are not there yet, but ideal state. If as we're thinking of, for example, I'm a neurologist, so as we think about Parkinson's disease, for example, those patients, in order for them to come to clinic, the caregiver probably has to take a day off. They have severe mobility issues. Uh, are there ways that remote patient monitoring could help? Can we measure their gait? Can we measure their tremors? And how do we leverage our EMR, whether it's, whatever EMR different systems have, we have Epic. How can that be pulled into Epic? How can the physician have access to that information in real time and make adjustments to their medications? And how can we avoid this patient from coming to the clinic for their visit. So I think even though, yes, that falls within remote patient monitoring, but I would still call it like a process improvement in the way care is delivered. So I would say that most of the work that we have right now is going to be within process improvement. However, you're right that the technology that is coming in, it is changing the way we provide care. So is it going to change the standard of care for us? So how are we going to diagnose osteoporosis with this AI ambient technology? Will that change how we usually have guidelines set up? And how can we be part of the groups who are bringing these to the healthcare systems early and through experimentation? And when I say that, I mean like piloting, provide enough data that we can perhaps shape the policy discussions. I think that's certainly possible. I would like to think, but I think that's a little bit further up in our future than at the present time.
Fantastic. Well, I know we're kind of running up on time here, and I just want to see if, how can those that are interested in what Corewell is doing, how do they follow your work? How do they keep up with some of the things that you guys are doing?
We are really trying to have more of our national presence at conferences. So we try to present. We're trying to publish as well on our outcome-focused research. Again, we are new at this compared to some systems who have been doing this for much longer. I think reaching out is always helpful. I think, your forum is an example. I think LinkedIn and your forum and similar forums, national meetings are the best way for all of us to brainstorm together and learn from each other. One place that I have found recently to be very helpful is these collaboratives through HMA Academy that are focused on different lesson learned type of initiatives. Because I think when we pilot, we learn that we were what we thought. It didn't turn out to be that. And now with the information we have to pivot. And I think we are all experimenting, all organizations are experimenting. And certainly there is an opportunity for us to disseminate it through newer forums that are now virtual, instead of just meetings. But
do those get together at all, those collaboratives, or is it strictly virtual?
No, they do get together twice a year.
It's fantastic. So, how big are those cohorts? I mean, and it's sort of with your peers?
Not terribly. I would say not more than 50 people, I would say. So
you can really kind of go deeper than in this sense.
Yes.
Really interesting. That's really fantastic to hear. And if there's one thing, because, we talk about it in our group that we're about taking action, decisive action, execution. Ideas are great. Execution really is what matters. If there's one takeaway from this conversation that you would like someone to take action on, if you had to put your finger on it, what would that be?
Sure. To reach out to your peers and think of ways of designing care together. I think this is something we often don't think about. And I have a role within my Society for Neurology, which is American Academy of Neurology. And this is becoming very clear to all different committee chairs that we have an opportunity to sit down and think a little bit more proactively than in a more reactionary way to reduce the administrative burden for sure, but in addition to really think about designing benefits and designing ways to provide care differently, whether it's through goal carding, whether it's creating clinical pathway, or whatever way we a center of excellences. But that's probably one area that is often underutilized. And we are certainly exploring that through our pay-wider relationship. And I would say we're still early in our journey with this relationship, but it is something that even if you don't have an insurance arm, it's worthwhile exploring.
Yeah, what you mentioned there isn't a novel idea. However, it's powerful. And
Mhm.
like you said, often underutilized. And sometimes it's because people feel like you're sitting at opposite ends of the table. Doesn't necessarily mean that you couldn't come on the same side of the table and say, look, we have a lot more aligned than is not aligned. Let's focus on that. And that really boils down to a relationship, as you mentioned earlier. Patients have a relationship with their primary care provider. Maybe there's a greater likelihood that they'll share more with their PCP than they would with a specialist. And who's to know? Same thing with your payer. Have that relationship, forge that relationship, take the time to do it. And I'm really, really thankful today, Dr. Ahmed, for you just, number one, taking the time out and just being so open minded, pragmatic, sharing some leadership lessons. And for those that have joined in, if you found this content helpful for you, would you mind sharing it on social media? Would you mind even just sharing it with your network and commenting and maybe even just listening in the comment section? You know, what was the one thing that you're going to take action on? I'd love to understand what that is. And I'm just so grateful when we have folks that are coming into the community that really want to make a difference. And when it comes to advancing healthcare forward, I'm even more grateful when we have innovators that are doers, that are executors. That's what's going to make the difference. So, Dr. Med, we'd love to have you come on again at some point in the future. And this has been a fantastic conversation. Great to
Thank
see
you
you
very
again.
much, Michael. I really appreciated the opportunity and it was great talking to you.
Excellent. Bye for now.
Bye.